All right, folks. Well, it's always exciting to have a first timer on Healthcare Unfiltered. And hopefully it's not the last time she's going to come on this podcast. But I feel, by the way, for the record, for those of you who are listening, I feel I am in the company of a celebrity. I admit I did not actually know of this celebrity before ESMO 2022 because I am not really in the GI oncology field. But I was there and I attended a presentation and I was just blown away, not only by the presenter and her command of the audience, but also by the science and the trial and so on. So guess what we do on Healthcare Unfiltered? We bring the author here, we bring the investigator here, and we talk about everything. So Dr. Myriam Chalabi, welcome to Healthcare Unfiltered. Very, very happy to get to meet you and to get to know you. Of course, congrats for all of your accomplishments, but let's start by getting to know you a little bit. Tell us about you, who you are, where you work, and how did you get to become a GI oncologist?
Well, first of all, thank you so much for having me. The feeling is mutual. I feel like I'm in the presence of a celebrity as well. So I wouldn't call myself a celebrity, to be honest. But I guess the attention that we've got after ESMO has been overwhelming and great. And so good to see that so many people's attention has been drawn to this study and to neoadjuvant immunotherapy in general. So that's been great. So a bit more about me. I'm a GI oncologist at the Netherlands Cancer Institute in Amsterdam, and I have been since 2016. And well, some things happened by chance, and GI oncology was not necessarily the first thing I thought about, but well, things happened, and I believe in taking opportunities when they come along. So that's what I did, and I was working at the Netherlands Cancer Institute at that time, and I stayed, and I think this has been the most fantastic place to develop, especially when you're interested in immunotherapy research, together with a specialized cancer center that we are, that has been a fantastic mix with excellent colleagues as well. So I guess that was how the niche was born and all the sequels to the niche study. And it's not one person, that's never possible. So it's a whole lot of people working together to make this happen. So I'm very, very proud of what we've accomplished, but also very happy with everybody that has accomplished this with us.
We were talking before we went on the air, Myriam, that you know, we have kind of similar origin, you know, from the Syria and Lebanon and all of this. What got you to the Netherlands? Because you were not born in the Netherlands, were you?
No. I was born in Lebanon.
Mm-hmm.
So to a Lebanese dad and a Syrian mother. And I was born in Lebanon. We lived there for 5 years. And when I was 5, yeah, that was during the war. And I think it's a reality for many people. So we left Lebanon when I was 5 and actually went to Curacao. So that's an island in the Caribbean. And well, that was also chance. So we had family living there, and there was an opportunity for my parents to actually work there. So things worked out, and we spent, well, my parents still live there in Curacao. It's a very small island where a lot of, well, of course, this is a mainly American audience, so people will recognize a lot of.
No, we're global. We're global. Hopefully, a lot of people are listening from Lebanon, Syria, Dubai, everywhere.
Definitely. But so a lot of baseball players actually are from Curacao. And well, that's the island I grew up in and Curacao is part of the Netherlands. So that was the logical path to actually, when I wanted to pursue medicine, to go from Curacao to the Netherlands. And that's how I got here. So it's been a
fascinating. Yeah. Fascinating. Did you always want to be a doctor? Did you always want it to be growing up?
Yes. I think from the moment I started, realizing what a doctor was, I was saying to my parents, I wanted to become a doctor. The oncology part came later. I actually wanted to become a surgeon first, but I guess that's how it starts for many med students. But I quickly saw the light and became an internist and then an oncologist.
Well, that's wonderful. It's a gain to the field of oncology and medicine and a loss for the field of surgery. But so you, hold on. So So you were born in Lebanon, you must speak French.
Yes, well, French is the least of my languages. I do speak it, I understand it quite well, but I wouldn't do a podcast with you in French.
No. I mean, and if Dr. Tony Shweri and Dr. Tony Saba are listening to this podcast, their French is terrible, by the way. They claim they speak French, but it's awful.
Okay, then maybe that's the same level.
Yeah. So you speak French, you speak Arabic, you speak English, you speak Dutch. What else do you speak?
I speak Spanish.
You speak
Because I
Spanish.
actually grew up speaking Spanish with a nanny at home. So Spanish was kind of my second language at the time. And I speak the local language of Curacao, which is Papiamento. Not a
Wow.
very global language, of course, but it's a beautiful mix of actually Dutch words, but also Spanish, Portuguese, and African words. So I think it's a beautiful melting pot, and the island is as well, but the language also.
That is amazing. You have a fascinating background. So, you started doing GI oncology, and, how do you split your time? Is it only seeing patients, clinical research? Do you do something in the lab? Like give me a pie chart of how you spend your academic life.
Yeah, so that has changed over the past year or so. Before, I used to do mainly clinic, 4 days a week, and 1 day a week would be research. And well, things started becoming quite big and very well busy, and which is since last year I divide my time 50% for research and 50% for clinical work, and research is a mix of I guess writing, meeting people, discussing ideas, how to go next, what to do next. There's a lot of lab work, translational work also involved. So of course the clinical part of the studies is the most visible, but there's a lot also going on in the lab, and which will come after studies are published. And that's also my passion. I love the translational part of the work, and I think especially with the neoadjuvant setting of studies makes it very much easier to get beautiful paired biopsies, and data that will come out of it is going to be a gold mine, I think, to understand better what we're doing, why it's working for one patient and not for the other, and how to improve it ultimately. And I think, well, it's probably not a holy grail, but there's so much to be learned from that. And yeah, so my passion is both for the clinical side, but also much of the translational lab work.
And there's a lot that at least every field in oncology has become a little bit subspecialized. Like, I mean, at least in the US, some folks will only see colorectal, and some will see pancreas and neuroendocrine tumors even. Is it the same in the Netherlands? Like, are you just specialized on one focus within GI malignancies?
Yeah, it depends a bit on the hospital, but in my case, so I see mainly colorectal cancer patients, but I also do some upper GI, and also because I have clinical trials in upper GI with immunotherapy ongoing. So I see both patient groups. Of course, colorectal cancer is the biggest patient population, and that is most of my population, but not pancreatic cancer or other GI malignancies.
To give you a context of how old I am, Myriam, which is very scary when I mention that, but when I was in fellowship, when I was in training, do you know what was the biggest, most pressing GI oncology question? The biggest one was, how do you give 5-FU?
Oh,
do you give it bolus, the Mayo Clinic? Do you give it the Roswell Park regimen? And then Zilloda came in. It was like the Nobel Prize. We actually got Zilloda, and it's funny. Well, obviously, for the non-GI oncologist in me, I was fascinated by what I saw when I attended your talk. And we're going to talk more than just your study, but take me through the birth of the niche study, which you were the primary investigator in. Take us through the background, because I know, as everybody hopefully on the podcast knows, that while the presentation happened a month or a month and a half ago, this was years in the making. Take us through the process until the birth of the study.
Sure. It's a story I actually like to share, so I will do that here. I got inspired by a colleague who was doing immunotherapy trials in breast cancer patients here at the NKI. And that was in the last part of my specialization, where I was an interim study coordinator for that study. And I thought, hey, this is something I want to do too. But I want to do it for patients with colorectal cancer and GI malignancies. And there was not much going on. And this is 2015. There were some data coming out, but there wasn't that much going on. So, and here at the NKI, so we have Christian Blank, who is a professor in melanoma research immunotherapy, and he was actually one of the first ones to do neoadjuvant immunotherapy studies. So that combination led to me thinking about, okay, where's the unmet need? Where can we gain? Especially knowledge, because first it was more looking to understand better how these colorectal cancers would respond to immunotherapy. And that's how the niche was born. And the idea was back then to treat patients with both pMMR and dMMR tumors, so the deficient and the proficient tumors, with a very short cycles of immunotherapy prior to surgery, to be able to study those paired biopsies.
So just for the non-GI oncologists in the audience, a little bit about what you mean by dMMR, and because some of the listeners may not be GI oncologists.
Sure. So the dMMR are the MMR deficient tumors, also the microsatellite unstable tumors, and the pMMR are the MMR proficient microsatellite stable tumors. And we knew back then already that the MSS tumors, the pMMR tumors, were not responding to immunotherapy in the metastatic disease setting. So, of course, that's the biggest population. That's 95% of patients with metastatic disease, but they were not responding. And well, we didn't really understand why. And the idea was, or our hypothesis was, that if you treat earlier on, you have a much larger population of MSS tumors, pMMR tumors, that have high infiltration of CD8 T cells. And so maybe if you treat them early on, there would be responders and you would have a higher chance of response. And then we wanted to treat MMR deficient tumors as well, or patients with these tumors, to compare how these tumors differ biologically also when you give immunotherapy. So it was more of a window of opportunity study back then, without even knowing what to expect. We had no idea that was going to be this successful and that the responses were going to blow us away, well, and basically blow the tumors away in such a short treatment period. So we started, that's when I started writing the study, and that was in 2016, the protocol, and discussing with pharma. That was BMS was very interested. And in 2017, the study started. And what I love when I think back about the first couple of patients that we treated, especially the patients with dMMR tumors, the first patient was treated, and then we saw that, well, the tumor was almost gone. I'm like, no, that's not possible. But okay. Then the second patient, the same thing happened. And the third patient, the same thing happened. And then I'm like, well, this is probably not chance anymore. And how is this going to go on when we treat more patients? And it just kept happening. The one patient after another having these fantastic complete or near complete responses in that very short time frame. And what was interesting, so the dMMR tumors were responding very, very well, but we also had responding MMR proficient MSS tumors. And we published that work in 2020 in Nature Medicine, showing that both tumor types can respond to immunotherapy if you give it neoadjuvantly, and that our hypothesis, and whether the hypothesis that we had based on the CD8 T cell infiltration, whether that was the reason, well, we don't know, but we did find something. So by now, about 29% of patients with pMMR tumors are responding to neoadjuvant immunotherapy. So that's already a very cool part of the study. But of course, the MSI tumors, and that was the ESMO presentation, everybody was responding. So we thought, okay, that we had included all the 30 patients that we wanted to include in the study, but I couldn't leave it at that. We were doing something great for these patients, especially for those patients with the very big, nasty, bulky tumors that you really want to give induction treatment to. So then we decided to expand the study and to add an arm, actually, with a new primary endpoint, which was a disease-free survival, and well, to treat these patients with neoadjuvant immunotherapy. And that's how we got here. So
Really, it's
initiation of the study was
serendipity. Some
yeah.
of these things happen with serendipity. So let's go back a little bit. You had the idea, obviously, about giving the neoadjuvant immunotherapy for the dMMR tumors. And
Mhm.
how difficult was to get funding and the negotiation with BMS, you said, and how did you decide? I mean, at the time, I presume there are so many immunotherapy, IO therapies out there, right? Drugs with IO. So how did you decide which IO you can accomplish, and how difficult was it you have to sell the study to the funders? I mean,
Yeah,
let's face it, right? I mean, so
definitely.
how did that happen?
Yeah, so well, that's another story of serendipity. I was visiting a friend in who was actually doing a part of a postdoc in Baltimore at Johns Hopkins, and I was there, and she was going to a BMS meeting, and then there was a call also within that BMS meeting for GI cancers and immunotherapy, and I already had been writing actually. So things came together, and then, well, I asked around if I could also attend the meeting, and that was possible. So I attended the meeting. I pitched the study, and they were interested. And it started with a relatively small budget, but I was happy with any budget we could get at that time. So I actually didn't look at other companies because this happened by chance, and they were
Yeah.
interested. I have to say, BMS has been great in a lot of what we're doing. So that was a perfect match at the time, and still. But yeah, being at the right place at the right time is
That's
definitely
amazing.
not cliche.
That's amazing. And so let's just, for listeners who may have not really, let's just maybe distill the study design. Like, what was the study? It was any comers with metastatic colorectal cancer. Maybe just you tell us the study design just in its details.
Yeah, so the study is for patients with non-metastatic colon cancer, so no, not rectal cancers. And when we expanded to the niche 2 and added that cohort, we also changed the inclusion criteria, where we try to include only patients with locally advanced disease. So patients with colon adenocarcinoma without signs of metastatic disease, without signs of clinical obstruction or perforation, and patients who had, for this part of the study, MMR deficient tumors or MSI tumors, and also at least T3 or N plus based on radiological staging. That was the patient population that we treated in niche 2. And what we noticed is, of course, the data, and that helps, of course, when you have some data that have been published before. So we published the first data with 20 patients with MMR deficient tumors with 100% pathologic response in 2020 already. So the fact that that data was out there and people knew it, then it becomes also easier to get patients referred, and because what patients can gain from it. So what we notice is that patients, especially who need induction treatment, so the T4 tumors, the patients with very bulky disease, those were the patients that were usually referred to participate in the study. And that's why we have such a high percentage of patients with T4 tumors.
And Myriam, again, some of my questions are stupid because I'm not a GI oncologist, but also because my listeners may not be also oncologists. But when you do the neoadjuvant approach and you start having these amazing responses, and we'll go over your presentation a little bit, is it tempting from the surgical perspective not to do surgery? I mean, is it like, if you're a patient, right? If I'm a patient and you tell me the tumor melted away completely, it's tempting to say, well, maybe I'll just sit. Like, how did you handle that? I'm pretty sure this question came up.
Yeah. Yeah, definitely. It's everything but a stupid question. I think this is a very actual question that, well, both doctors but also patients indeed do ask. So we did not show that data for this part of the study, but we previously did show some data on if we do CT scans prior to surgery, so just a couple of days maximum before surgery, we do see responses, but we do not see the complete responses. We're not able to say that these patients have complete responses. Also, when you have the operation, and you look at the macroscopic specimen, and well, when the pathologist looks at it and I'm standing next to him or her, there's still something there. There's still tumor, only it's not cancer. But that's something we find out after the microscopy has been done. So that's definitely something that we really need to work on, because, well, when a patient comes back to me, I tell them their pathology report. Yeah, you have a complete response. Everybody's, of course, super happy because, well, I also am enthusiastic about sharing that news with my patients. I often call them, even though they don't have an appointment with me at that time. I call them as soon as I have that information, because, you know, it's wonderful to be able to share that. I have that with every single patient that I see. But yeah, so some of them do ask in hindsight, but yeah, why did you let the surgeon operate me? Couldn't we have just went ahead without surgery? So that's a very good question. But I think the main answer is we really need to make sure that we're able to tell and assess adequately whether there's a complete response. Because in rectal cancer, we're used to that a bit more with a wait and see and watch and wait cohorts. But in colon cancer, of course, that hasn't been done before. And it's quite difficult to stage colon cancer. So maybe if we treat longer, if we're going to wait a bit longer, then at some point those tumors are going to disappear also on CT scans. We're working, so soon we're going to start a neoadjuvant study for the irresectable dMMR colon cancers, because niche is only resectable. And of course, there's a, how do you say that? There's a bit of a gray area, what is resectable and what isn't. But yeah, we have tried to make a definition for that. So irresectable tumors are those where you need to remove multiple organs to be able to resect a tumor, or where it's growing into the aorta or other important vascular structures. But that's a patient population where we're going to give neoadjuvant immunotherapy to and follow up with CT scans and with endoscopies, and hopefully that will, and also with the liquid biopsies, and hopefully that will inform us on how these tumors develop over time, and whether if you wait longer, you're going to see that with endoscopic assessment and with CT scans, you're going to be able to tell that these patients ultimately have a complete response. That together with the liquid biopsies from niche, I think when we analyze those, that's going to help us a lot if we have the pre-surgery liquid biopsies and the dynamics thereof. And if we see that there's a clearance of ctDNA, you know, that's all going to help us into doing a next study where you omit surgery. But it has to be safe for patients, and we have to have not 100%, because that doesn't exist in medicine, but a fairly high percentage of
benefit risk ratio, right? And it's always the benefit risk ratio. Myriam, was the study that you had niche to, was it global, US, Europe, everywhere, or was it like how many sites were there, or just in the Netherlands?
Study, so only in the Netherlands, and we had a total of 6 participating hospitals in the Netherlands.
Okay, so now you had the study and you decide to write it up and send it to ESMO, European Society of Medical Oncology, which took place in September in the beautiful city of Paris. What were your expectations as you were writing it? I mean, you must have been expecting that this is going to get a lot of attention. I mean, there's no way you would have not expected that, no?
It's funny how things go when you know your data. I've been seeing this for the past years, the one after the next patient responding, having these dramatic responses, and I'm, of course, very excited, but then sometimes you wonder, okay, am I being biased? And sometimes you forget how fantastic, phenomenal these data are. So when I was preparing the talk, I was looking at the waterfall plot, and I would say, okay, this is really cool. And then but maybe not everybody thinks this is cool. And so it's weird, like how your mind works. So of course I knew the data were fantastic, but I would look also at the downsides. So for example, this is a single arm study, and that's going to be, some point of criticism. And you think, well, I don't know if everybody has that, but you start to think in, well, actually, as if you're writing a discussion part of a paper. What are the limitations, and how important are those limitations, and how people are going to perceive your study and results? But
I
all
was
in all, I
reading,
was, of course, excited.
of course. Well, I was reading some of your tweets before your presentation, and you sounded a little bit nervous that you're gonna give that talk. But I'm like, there's no way she's nervous. I mean, she's, this is gonna be a no-brainer. Were you nervous a little bit getting in front of thousands of people, whether they are listening virtually or they are watching you?
I have to say that I was nervous the days before preparing. It had been a very busy period beforehand, and ESMO was very busy. But on that day, I was confident. I was sitting there, and well, I had talked a bit to Sapna Patel, who gave the talk before me on neoadjuvant immunotherapy in melanoma, and it was great to be sitting next to her. And yeah, so I guess when I had to walk up on stage, I wasn't feeling those nerves anymore. I was ready, and it felt good. And we had a huge, so a whole block of the front row, a couple of front rows, was all NKI people sitting there and cheering me on. So that was also a great feeling to have, that that there's so much support from colleagues from the NKI, but also like Tony Shueri and all these other fantastic people that that are rooting for you. The GI oncologists from different international centers. It's great to be able to feel that support. And I think when we're supportive of each other, it helps not only the person who has to do it, but it also helps be working together in the future. It stimulates a whole lot more than just that support at that time. So no, it felt good at that moment.
Well, I was cheering for you in the back. I try to avoid sitting by Tony Shueri as much as possible. I mean, the room is not too big for both of us, so some of us has to be somewhere. But I was really, just watching this, and then you put on the waterfall plot.
Yeah.
And I mean, I literally gasped, and I honestly think everybody in the room gasped. Like, I've never seen anything like this. And I probably give a credit to Tony, because he started the Chalabi plot, if you remember this, and it literally got like, it trended on Twitter for like, I mean, everybody was talking about it, because I have never seen anything like this. And I don't know, I remember you paused a little bit to hopefully savor the moment, but I mean, this was unbelievable. Take me through that moment. I mean, I don't know, this was very amazing.
Yeah, so this was, of course, also to experience that was and is still special, because I think about that moment quite often, and it's crazy and overwhelming and, well, beautiful. Well, I, of course, had rehearsed a lot on what I wanted to say, exactly the words. I wanted to make sure I didn't omit anything that was important, because, of course, you have this limited time and you want to make sure that you say everything that is important. I had never rehearsed to say, this is a waterfall plot. But I was standing there, I showed the waterfall plot. I knew it was beautiful, but then I heard those gasps. And that was what made me pause, because I heard that, I felt something, and then, well, the unrehearsed part came out, and then I said, this is a waterfall plot. And, well, that's when everybody started laughing. And yeah, I was savoring that moment. I, of course, had to wait until the applause was finished, but that was that was.
Well, you had an applause, and you had some standing ovation as well.
Yeah.
I mean, that was this. I would say this does not happen very often at these meetings. So, and I know how passionate you are about patients and patient care. I mean, ultimately, to put that waterfall plot on the screen, and for you as the investigator, and probably as somebody who took care of a lot of these patients, this must have meant so much to you.
Yeah, that was wonderful. And of course, I was standing there on behalf of these patients, because they entrusted us, they participated in the study, and they had these fantastic results. And it's well, of course, you have these you have patients that stick a bit more than others. And so many of these stories are so incredible. And so, for example, one of them that always comes to mind is this young lady with who came to me for the first time together with her husband. They weren't. They were just in the Netherlands from abroad, living here for a couple of years probably, and they came with their 3-year-old son. And he was sitting there with these beautiful big eyes, and and well, she had a very, very bulky tumor, large tumor. We had to really look, okay, does she fulfill the inclusion criteria for the study? Ultimately, yeah, we thought she did. We really wanted her to. And after she was operated and had a complete response, all I could think about was this little boy. And thinking, okay, so probably because she participated in this study, this little boy is going to have a mother, because otherwise, I don't know if that would have been the case. And yeah, that gets to me. And there are so many of these stories. So that's what we do it for. And those are the type of patients and the patient category that you want this to be successful in. And of course, you want this for everybody, but having at least this patient population respond so well and having these effects, not only in the short term, because I actually really believe that we are curing these patients. Yeah, that's so special. And then the thought that every one of those bars on the waterfall plot is one of these patients. Yeah, that's just.
And and at least in this study, it's almost everybody. I think it's 95%. Like it's really. And I recall, because I was sitting in the back, they have all of the screens, so you could see although you're not up front, I could see you on the podium. I could see how happy you were with the recognition, but I could also see that you got emotional.
Yeah, I had to get myself together, because I realized, okay, this is not the end of your talk. You still have a very important part of your talk to go. So, okay, get yourself together and don't become too emotional. But it's, it was and I think I tweeted about this. The smile and those emotions were that feeling that people were experiencing what I had been experiencing the past 5 years, that each one of these bars is a patient and that we're treating that has a fantastic response. And I know many of these patients, most of them by name, and many of them I've seen. So that was that part that got to me, that people were seeing this. And that was that was an emotional moment.
It's an amazing, again, as someone in the audience who was watching this, I really was affected by this, and I was clapping for you in the back. It was really amazing, because it does take, I think, look, we all know that this is about patients, but it's also about the perseverance of the investigator. At the end of the day, of course, patients won, but you had the idea, you got the funding, you went through the process, and that's really why patients benefited. So it's only fair that the investigator and the treating physicians do share some of this triumph with patients. I don't want to take anything away from patients, because this is really about patients, but at the same time, you were the one who led this. So kudos to you. This is amazing. And I probably should know this, but I actually don't. So I'll say I don't. Is it published yet?
No, not this yet. That we're working on. We published the first part from Niche 1 in 2020.
Okay. Niche 2 is not published yet.
No, that we're working on now.
Okay. So well, better be New England Journal of Medicine.
Yeah, we're working on. We're aiming high, definitely.
Well, yeah. Come on. That's probably, you could go higher than New England. Yeah. Let's see which one. But there's no question. This is looking forward to sharing this broadly with people once it gets published.
Looking forward indeed to not only with the oncology community, but also with the gastrointestinal surgeons, gastroenterologists. Everybody who sees these patients has to know this. Also to to realize why it's important to test for MMR deficiency, why you should be, especially when you consider the neoadjuvant chemotherapy in the same patient population, working in only 5 to 7% of patients. You really need to know that, and the difference between that and neoadjuvant immunotherapy when you're treating these patients. And so I just want to come back to something that you said about well, kudos to the investigators and perseverance. One important point there that I'd like to highlight is when we talked about how the study started. And I have to say that when I started talking to people about the study in the beginning, so many were very apprehensive, hesitant. Yeah, this is a very high risk, and you're going to treat patients with a combination immunotherapy prior to surgery, colonic surgery, and that's going to be, you have a very high risk of complications. And well, we persevered. Of course, we were being very careful and making sure that we had run-in periods and things like that. But what I also, and yeah, I'm happy that we did persevere because that's what got us here. But especially those first couple of patients that were included in the study and participated in the study, they had no idea what they could expect, and neither did we, but they still did. And that's a great example, I think, of the combination of both perseverance from the PI and the whole study team perspective, and also from patients who do it not because they know that they're going to gain something from it, but because they want to help the well, the science further. And yeah, the first couple of patients on the study are especially dear to my heart because yeah, how they thought.
I mean, they want to help the science, but they also trust their team.
Exactly.
I do think there's an element of trust there that you've established with them when they meet you and they meet the team. That trust factor makes patients willing to actually go the extra mile. If that trust is not established, they won't do it. So I want to go back to something you said that is a little bit intriguing. So Myriam, do you see a lot of physicians not testing for dMMR? Today, we're 2022. If you take 100 colorectal cancer patients, how many do you think get not get tested? I'm surprised to hear that.
Yeah, so I think it will depend on whether it's a primary tumor without metastatic disease or not. Let me start with the latter. In metastatic disease, I think by now most patients are tested, but we still do come across patients that haven't been tested. I think, well, that's a very small percentage, but it's still there. And if I also follow my my fellow tweeters and see also what they're concerned about, that this does happen more often than it should, especially, you know, if you're not going to treat a patient because they don't want treatment, or then I understand not testing. But as soon as you're going to treat patients systemically, it's not acceptable for patients not to have been tested for MMR proteins or MSI, but it does happen. And in the non-metastatic setting, I think there it happens more often because it doesn't always have direct consequences. But of course, for Lynch testing, underlying Lynch syndrome, that's important. And well, for a long time, and I think our guidelines are changing, and maybe that's the same in different countries. I'm not sure, but in the Netherlands, it was a long time the case that patients 70 years or older were not routinely tested for MMR deficiency, because the chances of having Lynch syndrome are very small, and hence it wouldn't have too many consequences. But that's back in the time when MMR deficiency was only important for Lynch syndrome, and those times have changed drastically. So we really have to make sure that people know about immunotherapy in metastatic disease and early stage disease, and test these patients. And even if you, for example, don't have studies where patients can participate in, let's say you have a patient with an MMR deficient colon cancer, and there's no way that you're going to be able to give neoadjuvant immunotherapy, which is the case for most countries at this time, unless you have a clinical trial. And you really need induction treatment, then you're going to give induction chemo. But you really have to know whether it's an MMR deficient tumor, because for MMR deficient tumors, I would then do evaluation scan much earlier on than if it were an MMR proficient tumor, because you know that a much larger proportion of patients with MMR deficient tumors are going to have progression on chemotherapy. And you don't want to miss that window of being able to operate a patient because you continue with the non-effective chemotherapy for too long. And well, also from a perspective of adjuvant chemotherapy, also in the patients over 70 years old. So I think all patients, well, I believe that all patients with colon cancer should be tested for MMR deficiency or
Well,
microsatellite.
we're certainly heading there. I mean, when I was in training, we were testing only in patients that you suspect Lynch syndrome. I mean, that was back in the day, and then it became for every. I mean, so it evolves, and I think that's what we're heading there. I mean, there's no question that this was the highlight of your ESMO, and honestly, I think yours and the melanoma trials were the ones for me, somebody who does lymphoma, I was very intrigued with. But in the world of GI oncology, aside from your study, what else at ESMO, for example, maybe a couple of other things that intrigued you or piqued your interest that may be relevant to what you're doing?
Yeah, so I think one interesting study was the FRESCO-2 study on fruquintinib in patients in later line treatment of colorectal cancer. And that was compared to best supportive care in mostly patients that had been previously treated with TAS-102 and also with the EGFR inhibition. And there was an overall survival benefit with fruquintinib. And I think that's it's not often that we see overall survival benefit in patients with the third or fourth line of treatment. So I think those data were very intriguing. I would be also very interested to see what happens if you give that much earlier on, because I think similar to immunotherapy, that probably also goes for chemotherapy, that when you give something earlier on, then it's going to be more effective. But I do think that there's a very high chance of us having that as a standard of care treatment in the foreseeable future. So I think those data were intriguing and very interesting. I also was interested by a project study presented by Julien Tayeb on second-line treatment of patients with MMR deficient tumors, where they treated with either second-line chemotherapy or immunotherapy. And this was for a patient population that hadn't received immunotherapy in the first line, and where you see that those patients still have a very high chances of response, even when they're later on in their treatment lines. And well, it does seem that the PFS is probably lower than you would expect for the first line treatment. So you should treat early on. But if you don't have, or if you find a patient that wasn't tested for MMR deficiency in the first line, received standard of care first line chemotherapy, it's still very much worth it to do second line immunotherapy in this patient population. And I think that was very good to have those data, because I hope it's going to be impossible to do a similar study, and that we're treating all of these patients in the first line. So I think this is probably, hopefully, one of the last studies in its kind for this patient population. So I think those were, for me, very interesting studies. And I think what I like is that we're also in colorectal cancer, and that took a while, but we're also going towards the more personalized treatment, the target treatments. So the KRAS G12C mutation in colorectal cancers also got a lot of attention at this ESMO, with both the Crystal-1 study and the Codebreak study showing some additional data after the previous data that had been presented, and that we were definitely seeing signals, very nice signals of response to KRAS G12C inhibitors together with the EGFR inhibitors, and those phase 3 trials are also ongoing, and I think very eagerly awaited. Even though it's a small patient population, that's where we're heading, to treat these patients with the most effective treatment, whether it's a KRAS G12C, whether it's an ERB2 amplification, the MMR deficiency. Ultimately, that's what we have to be looking for and find these subsets. And well, hopefully we're going to be able to identify more patients from the larger subsets and find a good and best treatment for that patient population as well.
Amazing. I mean, really, the field is really evolving so fast. It's difficult to keep up. So, I mean, how long have you been in practice, like as an attending physician?
6 years now.
Yeah. So, you know, there are people out there who spend 25 years as attending physicians to get one oral presentation and to get probably one paper like this. Truly, this is amazing progress in such a short time in the academic life of any investigator. So, in addition to my congrats, I mean, what's next for you? What is the next big thing you're thinking about? You're taking this. I mean, what's the next couple of studies you wanna use this as a platform to look at the next idea? If you can share, whatever you can share with us.
Yeah, of course. The niche is still ongoing. So for the MMR proficient MSS tumors, we have new cohorts that are currently ongoing. And what my aim is within niche, so it's an adaptive study and cohorts will be added as time goes. And my aim is for the MMR proficient tumors to develop some type of predictive biomarker for each combination that we're testing, and hopefully be able to do that also on a large scale. So do some signal finding first, and then do larger studies for the MSS patients. So that's something that is currently ongoing. We have two new cohorts that will start soon within niche. One is for the MMR deficient tumors, and that's with nivolumab anti-LAG-3, relatlimab. Also neoadjuvant, very similar design to niche 2. Let's see how that compares to nivolumab, ipilimumab. So that's exciting. And the same combination we're also going to test in patients with MMR proficient tumors. So we previously saw from another anti-PD-1, anti-LAG-3 combination that it was effective in patients with metastatic colorectal cancer in a small proportion. We're very excited to see how that translates into the neoadjuvant early stage disease setting. Next to that, we have I have a study ongoing in pMMR, mainly MMR proficient rectal cancers. Where it's called the Tarzan study, and we combine radiation therapy, so a short-term radiation therapy followed by atezolizumab plus bevacizumab, and with an endpoint of organ-sparing treatment for these patients. We hope to present the first stage of the study somewhere beginning of next year, and that's an exciting study, especially because you leave out all the chemo. You're not giving TNT. It's just bevacizumab, atezolizumab, and before that we give radiation therapy. So that will be exciting to share as soon as those data are ready. Another study that we also actually presented had a poster on at ESMO is the PANDA trial, which is a neoadjuvant anti-PD-L1 plus chemotherapy study in patients with gastroesophageal junction and gastric cancers. And that's a relatively small study with 20 patients, but very exciting data where we see 70% major pathologic responses in patients with mostly MMR proficient tumors to this combination, with 45% pathologic complete responses. So that's much higher than you expect based on chemotherapy only for the same patient population, and with a lot of translational work also involved. So that's also a very exciting study and a great signal, I think. And there are many studies ongoing on a large scale combining anti-PD-1 or PD-L1 with chemotherapy, but there's in the design of the PANDA trial where we give monotherapy anti-PD-L1 before combining it with chemo. That makes it so much different, and we have all these sequential biopsies from different time points that we are able to compare what happens after just atezo, what happens after you combine it with chemo, and what happens at the time of surgery. So, and there's a lot of stuff that's brewing I'm not at liberty to share just yet, but hopefully we'll be able to share that next time.
Well, we'll bring you back. That's why we'll bring you back on Healthcare Unfiltered. This has been so enjoyable. Getting to know you, just your background and how you became a GI oncologist, and really more importantly, taking us through the the steps that led to the design, inception, design of the trial, enrollment, up until you got on stage and you experienced what really, I would say, any academic physician would aspire to experience once in their lifetime. And I'm going to go and predict that this is not going to be the last time that you will experience this. We can tell a successful star when we see a successful star. Anything else I should have asked you? Anything you want to share as we part ways? And I cannot tell you how grateful I am that you spent an hour with me.
Oh no, I thank you so much for having me, and it's been great. And also talking about not only the science part, but also the personal part and how things came to be. And I think that's also important for people to know, that perseverance helps. And well, sometimes, well, as you said, it serendipity is also important. But there's a lot to be said on persevering and going for what you believe in, and of course. Being together with the people that inspire you. So surround yourself by people that inspire you, I think would be a very important message for me to share with people, because that helps so much and keeps you excited and keeps you enthusiastic. And well, meeting great people like you is also a fantastic experience. And thank you so much for inviting me. And
no, thank you. We need to have you back. I really appreciate, and thank you for spending time with us. So, Dr. Myriam Chalabi, the star, the one and only on Healthcare Unfiltered. Thank you so much.
Thank you. Thank you so much.